hypertension management issues. The chairman of today's program is Professor Arup Das Bishwas, who needs no introduction to this gathering, who is the ex-professor director and HOD of cardiology, SSKM Hospital, and is a very senior cardiologist in the city of Kolkata. He has also delivered lecture in our master classes. Without wasting time, I would like to hand over the mic to our chairman, Dr. Arup Das Bishwas. Over to Professor Arup Das Bishwas.
Good morning, Ananda, for the kind introduction. Good morning, all the dignitaries. Good morning, members who are present in the link and audience. I have a present duty to perform the chairmanship in a very present session. Our speaker is none other than Dr. Santanu Guha, my special friend, personal friend. He was the former professor and head of the Department of Cardiology. Everybody knows him in the Eastern India Circle. I have spoken about Eastern India Circle, taking that the audience should be in the Eastern India, but actually speaking, he is a national level speaker, national level teacher. Everybody knows him in the national level. And he will be speaking on a difficult subject. We know that hypertension is highly prevalent, almost 30% in the general population. And that is the root cause of death through the different organ system involvement, cerebrovascular, cardiac, renal, peripheral, retinal, everything. All the blood vessels, wherever they are getting involved into hypertension. And we all know that only about half of the people who are having hypertension are aware about their hypertension, and about half of them are being treated. And almost 10%, if not more, are suffering from resistant hypertension. Of course, when we talk about uncontrolled hypertension, it means persistent rise of 140 by 90 millimeter of mercury of blood pressure despite drugs. Now, when it is uncontrolled, majority will be finding that they are not just pure resistant, maybe due to severe resistance or other things. Particularly important is drug compliance. There are many ways to follow whether the patient is drug compliant or not. I think Dr. Guha will be touching upon those points also. So he will be speaking mainly on uncontrolled hypertension management issues. Over to Dr. Guha.
Thank you, Arupda. Thank you very much for your kind words and the nice introduction. At the outset, let me express my thanks and gratitude to the West Bengal, API West Bengal chapter and the West Bengal Forum of ICP Fellows, Dr. Amol Banerjee, and in particular, he invited me to give this oration. My sincere thanks to him. I will be discussing this issue, uncontrolled hypertension management issues. I will touch upon some of the important points. And as is obvious from the terminology, I'll be touching upon mostly the resistant hypertension and some part of non-resistant hypertension, as well as Dr. Arup Das Bishwas has just now said. Let us start with the definition of uncontrolled hypertension. Here itself, there is a problem. The definition of high blood pressure has changed over time and differs between guidelines proposed by the various expert bodies. For example, ACC/AHA guideline suggests the cutoff for high blood pressure is 130 by 80, whereas ESC suggests it is 140 by 90. The two most eminent bodies differ here. So what is uncontrolled hypertension? According to the ESC scheme, a person who is having a well-controlled blood pressure is uncontrolled according to the protocol given by ACC/AHA. So that is a confusion here. Second issue is uncontrolled hypertension. No, previous one. Kaushik, previous one, please. Uncontrolled hypertension signifies blood pressure that is either inadequately or improperly treated, or that is resistant to treatment, as might be observed in some secondary cause of hypertension like renal artery stenosis. Next one. In this, we need to remember, we need to just go through a number of definitions. What is resistant hypertension? Blood pressure that remains elevated above goal in spite of concurrent use of 3 or more antihypertensive agents of different classes, commonly but not exclusively, including a long-acting CCB, RAS blocker, and a diuretic, administered at maximal or maximally tolerated doses, and requires exclusion of the common causes of pseudo-resistance. Before I go to pseudo-resistance, here again, this definition as per the American guideline and as per the European guideline is bound to differ. In one case, it is above 130/80 despite treatment. In other case, it is above 140/90 despite treatment. Pseudo-resistance. What is a pseudo-resistance? The factors that can cause a falsely elevated blood pressure in a patient on 3 or more antihypertensive agents, such as improper BP measurement technique, white coat resistant hypertension, under-treatment, clinical inertia, medication non-adherence, etc. What is clinical inertia? The failure to establish appropriate targets and escalate treatment to achieve treatment goals. Next. A term is there, controlled resistant hypertension, that is a BP that is controlled on 4 or more antihypertensive medications at maximal or maximally tolerated doses. What is apparent treatment resistant hypertension? Term used when medication dose, adherence, and out of office blood pressure is not documented or accounted for, and the pseudo-resistance cannot be excluded in a patient on 3 or more antihypertensive agents. White coat resistant hypertension, previous. White coat resistant hypertension, the term used when office BP is uncontrolled, but out of office BP monitoring shows controlled SBP and DBP values in a patient on 3 or more antihypertensive agents. And the last but not the least, the term refractory hypertension, the BP that remains uncontrolled on maximal or near maximal therapy, which is a use of 5 or more antihypertensive agents of different classes, including a long-acting thiazide-like diuretic and spironolactone. Next. Looking at the epidemiology, increasing prevalence of obesity and hypertension in the general population has resulted in a higher incidence of uncontrolled and resistant hypertension. Prevalence of resistant hypertension is approximately 8 to 12% of the adult patients with hypertension. This is an American statistics. Studies show that patients with resistant hypertension who are older than 55 years, of Black ethnicity, with high body mass index, diabetes, or CKD have an increased risk for CV events. Next. The contributing factors, we all know about it for uncontrolled hypertension: low physical activity, poor dietary habit, overweight, systemic vascular resistance, increased lipids and inflammation and vascular disease, and elevated blood pressure. Next. Now, how we evaluate resistant hypertension? First, confirm treatment resistance. Clinic BP more than, this is an American scheme, so I am putting this figures. Clinic BP more than 130/80 and patient taking 3 or more antihypertensive agents, including a long-acting CCB, a RAS blocker, and a maximal or maximally tolerated dose of a diuretic. One need to exclude pseudo-resistance, confirm adherence to antihypertensive therapy, perform 24 hours ambulatory BP monitoring to exclude white coat effect. Next. Next one. These are the possible causes of pseudo-resistant hypertension: poor adherence to prescribed medication, white coat effect, poor office BP measurement techniques, and clinician inertia resulting in inadequate doses. And this pseudo-resistant hypertension should be evaluated and ruled out before concluding diagnosis of resistant hypertension. Next. Next one, yeah. Effective strategies for improving adherence to antihypertensive medication using agents that are dosed once daily, using fixed dose combination, educate patients, their families about the consequences of hypertension and possible adverse effects of medication, and using low-cost generic when cost is a barrier. Next. White coat effect, we all know about it. There is the observation of repeated BP elevation in the office with controlled or significantly lower BP outside the office in a hypertensive patient on medication. It can be easily identified by 24 hours ABPM. Next. Detection of white coat hypertension in patients on drug therapy. Look at the office BP. If it is at goal, if it is yes increased, there is increased CVD risk and target organ damage. If it is there, screen for masked uncontrolled hypertension with HBPM. If HBPM is above goal, ABPM may confirm it. And if yes, it's a masked uncontrolled hypertension, one need to intensify therapy. On the other hand, if the office BP is not at goal and it is 6 to 10 millimeter above goal on 3 agents, one should screen for white coat effect with HBPM. If the HBPM is at goal, it is likely to be white coat effect. It can be confirmed with an ABPM. Next. If the patient is not on drug therapy, and office BP is above 130/80, but below 160/100 after 3 months of lifestyle modification, and that one should suspect white coat hypertension. Here, the second part is important. If it is below 160/100, one should look for white coat effect. If it is above 160/100, one should not search white coat hypertension and straight away initiate therapy. Here, daytime ABPM or HBPM, if it is below 130/80, it is a white coat hypertension. One need to go for lifestyle modification and annual ABPM or HBPM to detect progression. If it is otherwise, this is a case of a hypertension and drug therapy should be initiated. Next. Poor BP measurement techniques. Inaccurate measurement of BP can result in the appearance of treatment resistance. Proper BP measurement technique entails preparing the individual by emptying full urinary bladder if it is there, and then sitting with legs uncrossed, back, arm, and feet supported in a quiet room, ideally 5 minutes before the first reading is obtained. Choosing a BP cuff of proper size, that is bladder length at least 80% and the width at least 40% of the mid-arm circumference. Placing the cuff directly on the skin without any clothing interspersed in between. On the upper arm at the level of the heart on the supported arm, and obtaining a minimum of 2 readings 1 minute apart. This I am talking about while using an oscillometric method with an automated blood pressure instrument. If we go ahead with auscultatory method of recording blood pressure, there are several other lacunae which can crop up and can enter and can trip up as improper blood pressure measurement, like rapid inflation, rapid deflation, holding the blood pressure cuff inflated, etc., etc. Next. What is clinical inertia? Clinical inertia is a major contributor to poor blood pressure control. Clinician inertia resulting in inadequate doses or irrational combination of blood pressure lowering drug therapies. Suboptimal antihypertensive therapy accounts for a large subset of patients not achieving BP target. In a study from US, around 50% of the patients were offered an optimal regimen and the rest 50% and not a proper antihypertensive regimen when in a study between 2007 and 2010 in a community setup. Next. Coming to the management issues, first is a basic workup. A detailed medical history needs to be taken. A physical examination should ascertain the target organ damage and possible secondary causes. Peripheral pulse, carotid pulse examination should be done. One should search for the bruit, fundoscopic examination, and BP to be measured in both arms and in thigh. Relevant investigations entails basic metabolic profile, urinalysis, plasma aldosterone concentration, aldosterone-renin ratio, plasma metanephrine, imaging for evaluation of renal artery stenosis with duplex ultrasonography or CT or MR angio, and abdominal imaging for adrenal glands. Next. Next. This is a management protocol of resistant hypertension. There are different steps. There are 6 steps altogether. Let us go one by one. Step 1 is exclude other causes of hypertension, including secondary cause, white coat effect, and medication non-adherence. Plus, ensure low sodium diet, maximize lifestyle intervention, like more than 6 hours uninterrupted sleep, overall dietary pattern, weight loss and exercise, plus optimize 3-drug regimen, ensure adherence to 3 antihypertensive agents of different classes, most commonly used being RAS blockers, CCBs, and diuretics at maximum or maximally tolerated doses. Diuretic types must be appropriate for kidney function. If eGFR is below 45, hydrochlorothiazide can be used. Up to 30 ml, chlorthalidins and indapamide are effective, but below that, only the loop diuretics can be used. I shall discuss these issues first before going to step 2. Next. Identify and treat secondary causes. An essential component of the management of resistant hypertension is identification and subsequent treatment of potentially reversible causes of secondary hypertension. The common secondary causes being obstructive sleep apnea, renal parenchymal disease, primary aldosteronism, and renal artery stenosis. Relatively uncommon causes are pheochromocytoma, Cushing's disease, hyperparathyroidism, and coarctation of aorta. Next. One need to stop medication that raises the blood pressure. A variety of medications can raise blood pressure and worsen underlying hypertension. Patients with resistant hypertension who are taking medicine that can exacerbate hypertension should discontinue the medication if it is possible. Here is a list of the medications which rises the blood pressure. Non-steroidal anti-inflammatory drugs, oral contraceptives, antidepressants, corticosteroids, decongestants, some weight loss medications, sodium-containing antacids, erythropoietin, cyclosporine, cocaine, etc. Next. Prescribe lifestyle modification. DASH or eating DASH diet or an equivalent diet to be prescribed. Reducing sodium intake and increasing potassium intake should be attempted. Losing weight if obese and overweight. Regular exercise and moderation in alcohol intake if patient takes alcohol. Next. Address non-adherence to drugs. Non-adherence to antihypertensive therapy is a major contributor to inadequate blood pressure control and is a common problem in patients who have apparent treatment resistance. Regimen should be simplified and long-acting combination agents should be used as much as possible. Treatment adherence worsens as the use of pills, complexity, and the dosing regimen and out-of-pocket cost increases. Medication-related adverse effects should be discussed and side effects should be addressed. Next. Coming to the stepwise approach to pharmacotherapy, by definition, patients with resistant hypertension are treated with at least 3 antihypertensive agents, including a diuretic, usually a thiazide or thiazide-like, but loop diuretics are selected in patients with GFR below 30. Specific regimen depends upon consideration of prior benefit, history of adverse events, financial limitations, and most importantly, the presence of concomitant disease process such as kidney disease and diabetes. Here I want to emphasize on one point. We need not be absolutely dogmatic.
Mute all other speakers, mics of all other except the speaker. Mute the mic of all other in the audience in the link, except that of the speaker. Dr. Guha, please continue.
Please. Thank you. I want to emphasize on one point that RAS blockers, CCBs, and diuretics should not always be the initial therapeutic regime before telling resistant hypertension. A patient with advanced CKD where we can and hyperkalemia where we cannot offer RAS blockers, these patients will also have resistant hypertension if the patient is resistant on 3 antihypertensive drugs. The general approach is to sequentially combine agents with different mechanisms of action. Next. There are 5 targets of therapy. One is the RAS system, taken care of by RAS inhibitors, ACE inhibitors, and ARBs. Vessel wall is taken care of by calcium blockers and directly acting vasodilators. Third is volume dependent action taken care of by the diuretics. Sympathetic nervous system addressed by beta blockers and alpha blockers, and central sympatholytics addressed by the centrally acting drugs. This slide shows the site of action of different agents and how they lower the blood pressure. Next. Regarding combination therapy, the combination drug therapy their action should be synergistic or additive. For example, CCBs plus RAS blockers. CCBs causes vasodilatation and renal hypoperfusion, increases renin release, whereas RAS blockers blocks that effect. Their effect is additive. A similar action is found with diuretics and RAS blockers. Beta blockers plus CCBs CCBs causes activation of the sympathetic nervous system, which is blocked by beta blockers. Beta blockers also blunt the increase in the plasma renin level that is induced by diuretics, and diuretics decrease the sodium and water retention that is caused by beta blockers. The blunting of the renin release is also applicable in this combination of beta blocker and CCBs. Next one. Undesirable combinations are beta blockers and AC inhibitors, beta blockers and centrally acting drugs, beta blockers and verapamil or diltiazem, AC inhibitors and ARBs, and two drugs from the same class. Next. While managing, we need to have a look at the recent guidelines. Unfortunately, though the theme is similar, the execution is different amongst most of the major guidelines. For example, let us see the ESC guideline. ESC guideline emphasizes on dual combination therapy or in a single pill, if possible, to initiate a therapy. So one pill dual combination of RAS blockers plus CCB or diuretic. If not controlled, step 2 is triple therapy, a RAS blockers plus CCB, it is not or, plus diuretic. If still not controlled, it is a case of a resistant hypertension and add spironolactone or other diuretic alpha or beta blockers. Beta blockers has their own place, like heart failure, angina, post-MI, atrial fibrillation, younger woman planning pregnancy, where beta blockers should always be used. Next one. Look at the International Society of Hypertension guideline. Theme is similar, but execution is different. Step 1 is a dual low dose combination of A plus C, RAS blockers plus calcium blockers. Step 2, full dose combination of A plus C. Step 3 is a triple combination A plus C plus diuretic. Diuretic has been relegated to step 3 in the ISH guideline. And step 4 is a resistant hypertension where spironolactone has been advocated. Next. In ACC AHA guideline, initial medication can be any one of these following: thiazide diuretics, CCBs, AC inhibitors, or ARBs. Next. Recommendation for choice of initial monotherapy versus initial combination therapy. Initial antihypertensive drug therapy with two first-line agents of different classes, either a separate agent or in a fixed dose combination, is recommended in adults with stage 2 hypertension and an average BP more than 20/10 above their BP target. American guideline is more objective when to initiate a 2-drug therapy. And initiation of a single antihypertensive drug is reasonable in adults with stage 1 hypertension and BP goal below 130/80, and dosage titration and sequential addition of other agents to achieve the BP target. They are more specific and objective about the initiation of the 2-drug therapy, which the European guideline is not. Next. This is the Indian guideline. There is some resemblance to the NICE guideline, where younger and older patients were considered. Younger patients below 55. Step 1 is RAS blockers for younger and CCB or diuretics for the older. Step 2, RAS blockers plus CCB or diuretic. Step 3, ACE inhibitor or ARB plus CCB plus diuretic. Step 4 is a resistant hypertension, where they recommended spironolactone if side effects eplerenone. 1 point, eplerenone, if given, should be given twice daily because of their shorter duration of action. And step 5, add alpha or beta blocker in special situations, centrally acting drugs or direct vasodilators. Next. Now, coming back to the management of resistant hypertension, all the facets of step 1 we have discussed. Now coming to step 2. substitute optimally dosed thiazide-like diuretic, that is chlorthalidone or indapamide for prior diuretics. If thiazides were given, it is better to switch to hydrochlorothiazide was given, it is better to switch to chlorthalidone. The diuretics with the greatest evidence base for reducing cardiovascular outcomes are the thiazide-like diuretics, chlorthalidone and indapamide. Comparative studies show an additional SBP reduction of 7 to 8 millimeter mercury simply by switching from hydrochlorothiazide to the same daily dose of chlorthalidone. Next. Next. BP not at target. Step 3 is add mineralocorticoid receptor antagonist, spironolactone and eplerenone. Next. Next. There's an addition of the fourth drug. There are some good evidences. We got some evidence from the ASCOT trial. And in patients who are not overtly volume overloaded, but who have evidence of low renin status or salt sensitivity of the blood pressure, mineralocorticoid receptor antagonist, spironolactone or eplerenone are more successful than alpha or beta blockers. Use of spironolactone as a fourth drug is limited by tolerability issues in some patients, including development of gynecomastia, development of hyperkalemia in those with CKD or with eGFR below 45 or a baseline serum potassium more than 4.5. So these two things needs to be remembered: eGFR below 45 and baseline serum potassium more than 4.5 for initiating spironolactone that can create problem. Next one. We get a very good evidence from Pathway 2 study. This is a study in resistant hypertension patients. They were randomized to undergo cyclically 4 treatments with spironolactone, with doxorubicin, with bisoprolol, and with placebo, each for 12 weeks duration, 6 weeks at a lower dose and next 6 weeks at a higher dose. Next one. It was demonstrated that spironolactone is overwhelmingly the most effective drug treatment for resistant hypertension. Spironolactone controlled BP in almost 60% patients with resistant hypertension and was 3 times as likely to be the patient's best drug versus doxorubicin or bisoprolol. Spironolactone was well tolerated with no significant excess adverse effects, with a caveat that serum potassium level and renal function should be monitored on treatment, and treatment duration was too short to assess the incident gynecomastia, which is in and around 6% in longer term studies. Next one. BP still not controlled after addition of spironolactone. Come to step 4. One need to check the heart rate. Unless it is below 70, a beta blocker or an alpha beta blocker should be added. If beta blocker is contraindicated, one can consider central alpha agonist like clonidine patch or guanfacine at bedtime. If these are not tolerated, consider once daily diltiazem. Still, BP is not at target. One should add hydralazine. And if patient is in congestive heart failure with HFrEF, add up isosorbide 5-mononitrate. Still not at control, substitute minoxidil. I'll come to a little detail with these issues. Next one. The choice of a 5th drug depends on sympathetic drive as assessed in part by heart rate. Agents such as beta blocker or if medically contraindicated, central alpha 2 agonists such as transdermal clonidine or guanfacine should be considered. Clonidine tablets should be avoided because of the need for frequent administration and the risk of rebound hypertension during periods of non-adherence and after discontinuation. Next one. BP is still not controlled. Add hydralazine. The addition of hydralazine should be considered and combined with nitrates in cases of heart failure. Nitrates are preferred in this setting because they help restore calcium cycling and cardiac contractile performance and control superoxide production in isolated cardiomyocytes. Hydralazine causes increased sympathetic tone and retains, and there is a retention of sodium and fluid. Hence, the concurrent use of beta blockers and diuretics are mandatory. Total daily dose of hydralazine should not exceed 150 milligrams, as it can induce a lupus-like syndrome. Next. If even with hydralazine, blood pressure is not controlled, minoxidil is a highly potent direct vasodilator with a wide dose range, 5 to 100 milligrams per day. Minoxidil is associated with profound fluid retention and must be administered with a loop diuretic. It induces major increase in sympathetic tone characterized by tachycardia and must be controlled using a beta blocker. It is not tolerated by women because it induces hirsutism, but it is a very potent drug along with beta blockers and a loop diuretic. Often other drugs can be withdrawn and the patient's blood pressure can be controlled. Next one. Next one. Till now, we have discussed the various drug therapies. Now, a few experimental therapy, some device therapy with one is a renal denervation. With renal denervation, a catheter is inserted into the renal arteries and radiofrequency or ultrasound is used to ablate the renal nerves which are located on the adventitial surface of the renal arteries. The RDM aims to destroy both efferent and afferent renal nerves, both of which are responsible for inducing hypertension. Next one. We have two randomized controlled trials, sham controlled trials rather. One is Simplicity Hypertension 3, another is Radiance Hypertension Trial. In both these trials, the primary endpoint was not reached, though there was some encouraging evidences in some subgroup analysis. So both that one can say the trials are negative, but further research is needed in this particular field. Next one. Baroreceptor activation therapy. With carotid baroreceptor activation therapy, electrical field stimulation of the carotid sinus nerve sends afferent neural signals to the brainstem, interprets it as rise in blood pressure, evoking a reflex reduction in blood pressure. The efferent arm of this reflex arc involves decreased efferent sympathetic nerve activity to the heart, which slows the heart rate, to the peripheral circulation, which lowers the systemic vascular resistance, and to the kidneys, which reduces the renin release and increases renal sodium excretion. Several trials in this modality are ongoing, but these are still experimental and should not be used in routine practice. Next one. So the key message remains, we have a number of very potent drugs to control hypertension, but drug therapy only is not enough. If it is not complemented by a strict lifestyle modification and the avoidance of the other things which raises the blood pressure becomes very difficult to control. So drug therapy plus other lifestyle modifications and other issues should be equally emphasized for the control of uncontrolled hypertension. Thank you. Thank you very much for your patient hearing.
Thank you, Dr. Guha, for nicely covering this difficult issue. There are some questions and comments both in the question answer box and chat box. I'll go to those things later on. Prior to that, I'll give you 1 or 2 case scenarios and how to treat. For example, one 15-year boy was sent to me. He was in the end-stage renal failure, undergoing dialysis, waiting for renal transplant. Now he has got an ejection fraction of 20%.
How much?
20%.
Achha.
With dilated heart, having dyspnea, volume features of volume overload, though he is under dialysis, and the BP is above 140/90 in this 15-year boy. So what could be done for this poor child till the renal transplant is done, and whether renal transplant he is suitable to go for renal transplant?
The second question first, with a dilated cardiomyopathy, like picture having a ejection fraction of 20%, one need to first see whether this part is at least significantly reversible. Otherwise, there is no point going for a renal transplant with this patient in per se perhaps requires a cardiac transplant as well.
I think at times what we have seen after renal transplant, many of the people dilated heart improves and comes
Yeah,
back.
that's what I said at the beginning, that
Yeah.
whether it is partially at least reversible.
Well, so how to assess that reversibility and which drug to use in this difficult scenario?
One can give a regular dialysis and other things and try to control the blood pressure with the drugs. Here, the minoxidil is one drug which is effective, particularly as a boy, you say. If the blood pressure is not controlled, one can use a vasodilators like minoxidil to control
And
the
what
blood
about
pressure.
hydrogen isosorbide dilated?
That can be given always. That
Yes.
should be tried first, because in my scheme of things, I say that is given first, particularly in a patient who is having HFrEF. And if not controlled, then only one should go for minoxidil.
Another thing, often we are successful in controlling hypertension, as you already have said, with the addition of a spironolactone or eplerenone. Do you think their adrenals should be investigated, or we can go on blindly with the therapy?
Just can you repeat? Your voice cracked once.
We are successful in controlling very often the resistant hypertension with the addition of a mineralocorticoid receptor antagonist.
True.
So do you think their adrenals should be interrogated further, or we should be just going on continuing with the therapy?
No guideline recommends it to be done routinely. So if you can go ahead with the investigations, see the adrenal level, see the adrenal renin ratio and other things. After that, if you suspect, you can go ahead with the imaging the adrenals and all, but routinely perhaps it is.
So
not
that brings us
recommended.
to another question. When you are dealing with resistant hypertension, and maybe in the refractory phase also, when to suspect a secondary cause and how to investigate them?
Secondary causes should be suspected if you cannot control the blood pressure, that is one, and if there are other telltale signs, like commonest cause of a secondary hypertension is a sleep apnea. If the patient is obese, if the patient has a history of snoring, if there is daytime somnolence, all these things points towards a sleep apnea, and one need to go through this polysomnography and all to see what is the magnitude of the sleep apnea. But one thing is certain, even using CPAP in a patient who is having obstructive sleep apnea, blood pressure control is at the best very modest. You cannot just expect that the blood pressure will be cured or it will be significantly lowered. Its effect is very modest. If a patient is having renal artery stenosis, like flash pulmonary edema and all, like you are getting a bruit. There you need to ascertain very properly what is the level of, what is the contribution of that. Renal parenchymal disease and pheochromocytoma, all these things, if somebody is having an episodic hypertension, because if I go on enumerating, this will be a very long list. But whatever list I have given, most of us know what are the usual phenotypes. For pheochromocytoma, for example, I tell you, a patient can have episodic hypertension with palpitation, headache and all, but this occurs in 50% patients. Rest 50% have a sustained hypertension. But an element of suspicion remains, and you can check the metanephrine, urinary or blood metanephrine for initial screening. So secondary hypertension should be suspected in a patient whose blood pressure is really difficult to control.
So that means it's a detailed history taking and thorough physical examination. From then to the list of investigation, rather than to jumping over to list of investigations. Select on the basis of history and physical findings.
Exactly.
And I'm going to the chat box. Okay, let's finish with the question answer box first. From Dr. Pratik Singh, Saurabh Pratik Singh. Sir, can you hear it, or you can read it by yourself also?
No, it is there. I can see. What should be
Okay.
the timing of different common classes of drugs, bedtime or at breakfast? Preferably, initially at least, should be given once daily. And one can try at the breakfast, but if you find that there is an early morning hypertension or nocturnal blood pressure is not well controlled, dosage can be given at bedtime. If that leads to a situation where during the daytime we are getting some amount of hypertension, but nighttime blood pressure is well controlled, you can even split the dosage. So this is an individualized thing you need to do.
Thank you. So going to the chat box. In the meantime, I'll also request other panelists, if they have got a question in their mind, they can keep them prepared. But we should focus more upon the students first. That's why I'm going to the chat box, then to the panelists. And how much time do you have? It is 21 past 12 now. By what time should we finish?
Arup, you can go on.
Okay, fine. Thank you. Dr. Guha, go to the chat box. Question or comment, why not spironolactone started earlier?
Just a second, let me see, Vijaya. Why not spironolactone started earlier? Basically, the hypertension, what we see is essentially of two types. Previously, the drug therapy was tailored accordingly. So it is a high renin hypertension or normal or to low renin hypertension. So spironolactone doesn't fit the bill in either case. It fits the bill in a patient who is having a salt sensitivity, low renin, and elevated aldosterone. So that scenario comes up once you treat the patient with the usual initial drugs like RAS blockers, diuretics, and CCBs. That's why if you give spironolactone initially to a patient having a blood pressure of 160 by say 100, this is unlikely to be effective.
Future of finerenone as an MRA.
I don't have any experience with finerenone, But it is a very promising drug. In the recent trials, it has been found to be very promising. And this is a new generation MRA which has come up. In hypertension, I don't think this is going to surpass the spironolactone and MRA, but it may be more helpful. It may be more beneficial in patients with heart failure, perhaps.
Role of spironolactone on advanced CKD.
Advanced CKD, we avoid spironolactone. In the scheme of things, I have mentioned that if the eGFR is below 45 and the potassium is above 4.5, it is better not to initiate these drugs because it is going to create problem.
Dialysis in CKD with fluid overload state.
So what is the question?
Two questions on fluid overloaded state. One is on Zytanix, another is on dialysis.
Zytanix, sorry, Zytanix in fluid overloaded state. Sorry, I didn't see that. Zytanix is a thiazide type diuretic which is effective in low eGFR, like almost like your loop diuretics. But Zytanix use in management of hypertension, we hardly have any data. Individually, though, I have seen many nephrologists, and I have also used in some cases with CKD where other drugs were not effective and the patient is volume overloaded. But I cannot give you any standard reference that what should be the use of Zytanix in hypertension. Second is dialysis. Sorry?
Yes, dialysis. Dialysis in CKD.
With fluid overloaded state, you take off more fluid. That is, we have this avenue open to us.
Any change of uncontrollable hypertension in pregnancy?
Any change of uncontrollable hypertension in pregnancy?
Patient is pregnant, BP is not controlled with usual drugs.
In hypertension in pregnancy, this pregnancy-induced hypertension or a gestational hypertension, whatever it is, the common drugs we use are very straightforward. We use alpha beta blockers. Labetalol is one of the very important drugs here. We use alpha methyl dopa. We can use diuretics with some risk of fetal growth retardation. We can use alpha beta blockers. Other beta blockers can also be used, but not so commonly used. Calcium blockers are useful. Calcium blockers most commonly used is a nifedipine. Nifedipine has the maximum evidence, evidence base. Also, amlodipine can be used. These are the drugs what can be given. If not controlled, one can go for the IV labetalol and all for the control and tiding over the crisis.
Particularly problematic happens in pre-eclamptic toxemia. Okay.
Magnesium can be used.
Magnesium for the prevention of convulsion and all, you have to go for IV magnesium.
Large vessel vasculitis and uncontrollable hypertension.
Vasculitis to be taken care of first, along with the standard medication for hypertension.
Uncontrollable hypertension, diastolic dysfunction, and SGLT2 inhibitor.
That is, we don't have any significant evidence of the role of SGLT2 inhibitors as an antihypertensive agent. Though SGLT2 inhibitors reduces the blood pressure, it has a diuretic-like effect and it reduces blood pressure, but no guideline has recommended SGLT2 inhibitor for the management of hypertension unless and until heart failure is present, maybe with reduced, maybe with preserved ejection fraction.
So this reminds me another question which may be asked. What is the role of ARNI in the control of hypertension?
Very good. I would have started this issue otherwise. Thank you. Thanks for raising this issue. ARNI is I can tell you about my experience, though the literature is very scarce on this. In some patients of resistant hypertension, ARNI has been used and with success. I find it a wonderful drug in some patients with hypertension, particularly with resistant hypertension, where it is difficult to control with ACE inhibitors or ARBs. I have used ARNI and got good result.
Another question is there on pregnancy with resistant hypertension management. So do you have anything to add?
Pregnancy
resistant hypertension management.
Pregnancy resistant hypertension, I think I have said about the beta blockers, I have said about the diuretics, I have said about calcium blockers, alpha methyl dopa, which is a very commonly used drug.
At this juncture, I would invite our other panelists, co-panelists, if they have to add anything on this issue or any other comments or question. Professor Banerjee, Professor Ganguly, Professor Mitro, and I don't find Shivendu over here, he was there.
Hello, Santanu. Am I audible?
Yes, you are.
Achha. I ask you one question from clinical point of view. You answer my question. For the last 20 years, beta blocker, the role and position of the beta blocker is going down in hypertension. But I think you will also agree that like me and many of us who are taking beta blocker for last 20 years should not omit it. And we can add AC inhibitor. But from your experience, I want to know that figure-wise to lower blood pressure, which drug you prefer in the Indian subcontinent, where we are mostly low renin, AC inhibitor or beta blocker?
Sir, essentially, we cannot say all Indians are low renin. It is
Most of us.
Elderly persons above, say, 55, as the Indian guideline has put the cutoff, it is preferably to say 60. Above 60, it is essentially low renin, but below that, it is normal to high renin. Low renin hypertension is better tackled by a single drug, if you say it is either a CCB or a diuretic. Whereas high renin hypertension, it is better tackled with either an ACE inhibitor or ARB, or if there is a sympathetic element is associated with it. Young man having a heart rate of 110 and a blood pressure of 150 by 110. These are the patients where only AC inhibitor or ARB may not work. Here the role of beta blockers is paramount. If there is an enhanced sympathetic drive, beta blockers has to be given. Otherwise becomes very difficult. And in the resistant hypertension also, in that scheme, once after spironolactone, if the heart rate, they have put it, if it is below 70, if it is not below 70, that is above 70, you add up a beta blocker. So beta blockers has not been gone down the drain. It is still there, though its use has been more selective.
And clinical profile also at times helpful, like presence of tachycardia,
Yes.
Exactly.
This clinical profile will determine whether he is sympathetically overdriven or not. And as Dr. Guha, you emphasized upon the age-dependent choice of the antihypertensive agent. My question would be, suppose the pressure was fairly well controlled with a couple of drugs with below 65. Do you think on the 65th and birthday, the drug regime should be changed?
No. My answer is no.
Just explain a bit.
Obviously, you
Yes.
need to see the profile. You follow up the patient. If the patient becomes blunt to these drugs, then you add up. Otherwise, why?
Okay. Anyone else? Would you like to comment?
One thing, Arup, regarding the two drugs which have been mentioned, why the spironolactone or MRA is not being used as a initial therapy. Everybody should remember that any MRA, whatever might be the molecule, there is a mild to moderate reduction of blood pressure. So usually it is being used as add-on therapy, particularly as mentioned by Santanu Guha, that since is usually placed in the fourth place, since a patient who is having the hypertension for some duration or long period, there is a chance of developing secondary hyperaldosteronism. There also MRA works. Same is applicable to SGLT2 inhibitor. Though everybody should remember that SGLT2 inhibitor is not being recommended as anti-hypertensive therapy. It has got, a patient with hypertension, diabetes, and some sort of LV dysfunction, where you are thinking of adding SGLT2 inhibitor, you always start with some reducing the dose of diuretic. Here is the same thing, that SGLT2 inhibitor very mildly reduces blood pressure, not even modestly. So it is not for the time being, it is not being anyway placed anywhere in the management of hypertension.
Another thing, I think, Amalda, have you finished or other? Okay. So is the choice of drug, multiple things come into question. One is what is the level of the blood pressure besides the patient profile, whether he is easily controllable with the usual drugs or not. Why I'm saying about the usual drugs, because we have to look into the price, into the side effects. For example, if we use aldactone at rampant, I think many cases will land up with gynecomastia or other estrogenic effects. And also the price, if we go on for eprenone in majority, it is a long-term use, almost a lifelong use. So may not be the price will be the, if we can use simpler drugs like a simple CCB or a low-dose diuretic, why not go for them at the start period? And is the evidence backup? How much evidence backup do we have for that drug? For the resistant hypertension cases, we have data on aldosterone antagonists, but not overall hypertension management in general.
And regarding this mineralocorticoid antagonist, there is an article in AHA. They have specifically said that if you use eprenone, use it twice daily, which many of us do not do. That's why I thought, let me just mention it here, that should be given twice daily. But issue is that becomes even more costly. If you give one tablet twice daily, eprenone, that becomes even costlier.
One more thing, Santanu, that there is a largest number of trial is spironolactone. Largest number of trial is spironolactone. Anyway, eprenone, they have the less anti-androgenic effect.
Yeah.
And for the finerenone, though it is not being recommended for the anti-hypertensive therapy, it has no anti-androgenic effect. Anyway, another issue regarding the beta blocker. Beta blocker as a single initial monotherapy is not indicated or recommended. It is being used as an add-on therapy, as Arup has mentioned, the patient having the unusual tachycardia or the angina or in patient with some sympathetic overdrive patient, in young patients, there might be benefited with the use of beta blocker, but everybody should remember that beta blocker is not recommended as single initial monotherapy. Initial monotherapy is not indicated. You know, there is a differences in molecule also regarding the peripheral pressure and the central pressure. I'm not going into that complicated discussion, but there are some role. Newer beta blockers which have got both vasodilatory effect, they can be used as add-on, particularly in if needed in elderly persons.
Thank you, Amalda, for the nice comments. In the meantime, another question has come up in the question answer box. So it is from Dr. Debraj Chatterjee. Any cutoff for de-escalation of drug in controlled hypertension? Could you go ahead the question, Santanu?
But just before that, just taking the cue from what Amalda was telling, it reminded me a very good joke by one of my teachers, one of our teachers rather, Professor J.C. Ghosh. One day, I asked him what drug you are giving for hypertension and all. He said very laughing that there are only 2 drugs which reduces blood pressure. দুটো ওষুধ blood pressure কমায়, CCB আর diuretic, rest are all bystanders. So when he was telling that beta blockers should not be given alone, of course it should not be given alone. Anyway, coming to the question, what is the question?
Question is
Any cutoff
for
de-escalation of drugs in controlled hypertension? This part is very well given in the European guideline. Debraj, if you go through that guideline, it is mentioned that the target of therapy for most, reduce it to below 140/90. If the patient tolerates it, reduce it to below 130/80, but not below 120/70. For most of the cases, excepting a chronic renal CKD, this is the scheme of things. If it is below 120/70, you can try to de-escalate a bit because we don't need it below that level.
Actually, suppose initially you started with 3 or 4 drugs to control the BP. Now you have better control and patient is going to have systolic BP below 120. And then you can reduce either the number of drug or the dose of drug in whatever way the patient suits. For example, if patient has got any specific complaint about a side effect, you can take off that drug or reduce the dose. There is no hard and fast formula, but it should be the patient-centric. Your approach should be not drug-centric, your approach should be patient-centric. I think it has been a very good and lively discussion. And if Amalda agrees, he can conclude the session by his final remarks.
Thank you, Arup. And Santanu also. Now I request Dr. Satyabroto Ganguly, who is one of our course directors, to give vote of thanks.
Thank you, Amalda. Now mine have a present duty to give vote of thanks. First, I will thank Dr. Santanu Guha for detailed discussion of this important issue, and also Arupda for chairing the session, and Dr. Amol Banerjee for managing the whole thing, and all our course director and who have joined here actively to help us. And also, I think they will also be benefited so that this endeavor continues. Now over to you, Amalda, for your final comment.
At one time, the attendee was above 30. Now it has dwindled to 23. So it is high time.
This is good. This is good, and it will be remain in the archives. It will be remain in the archives
and uploaded to the YouTube also. Anyway, Uh,
Satta, are you going to
now
give?
I
You had
am
a box
going
in
to